Hello and welcome everyone, wherever in the world you may be listening to this. My name is Dr. Michael Krigstein from St Vincent's in Sydney, Australia. My talk as part of Oncomine is entitled Utility of NGS in Lymphoid Malignancies and Our Early Experience with the Ion AmpliSeq Liverpool Lymphoid Network Panel. Here is my disclaimer slide. I'll just move on. I have no other relevant disclosures. So the talk today is going to be split up into two parts. The first part is on the role of NGS or next generation sequencing in lymphoid malignancies generally, why it might be useful in your lab and why we pursued introducing it in ours. And then part two will focus specifically on our early experiences with the Lymphoid Liverpool Network Panel. So just starting with chronic lymphocytic leukemia or CLL. So I guess how could NGS help? Well, from a diagnostic perspective, SF3B1 mutations are quite frequent and they're only rarely seen in other lymphoid malignancies, so it can be quite supportive to a CLL diagnosis. From a prognostic perspective, TP53 mutations or loss of TP53, which would be seen on FISH, is associated with chemorefractoriness and poor survival. So whilst TP53 disruption might not be that frequent, it's only about 5 to 10% initially at diagnosis, it does increase as patients relapse and progress through their journey. I guess it's also worth noting that BCL2 inhibitors and BTK inhibitors do improve the prognosis, but the patients still have an overall worse prognosis than those without a TP53 disruption. From a treatment perspective, NGS is becoming quite important. You can now pick up resistant mutations to the covalent BTK inhibitors, most commonly at the BTK binding site, the cysteine 481, as well as activating mutations in the gene PLCG2. Venetoclax resistance can also occur secondary to BCL2 mutations, most commonly at the 101 and 103 positions. Mantle cell lymphoma has a variety of commonly mutated genes, which you can see listed there. Again, TP53 is worth noting as being significantly prognostic and increasing in prevalence as the patient goes along their therapeutic journey with increasing relapses. Most notably, though, currently molecular results are not part of the prognostic scores incorporated in mantle cell lymphoma. My personal opinion is that's likely to change, but as of right now, they are not in the MIPI. Treatment resistance, interestingly, has been noted to BTK inhibitors, although has not classically been through the same BTK gene mutations, but rather through the NF-kappa B signaling pathway, such as mutations in CARD11 and BRCA3. Hairy cell leukemia, I think most of the audience would know that it's pretty well characterized by a BRAF V600E mutation, and that results in constitutive activation of the MAP-ERK pathway, which really just drives cell proliferation. Now that can be detected on immunohistochemistry, but it also can obviously be detected on an NGS platform. Whilst it's rare in any other B-cell lymphomas, this V600E mutation can be seen in other conditions like CLL, SLL myeloma, nodal marginal zone lymphoma, and histiocytic disorders. Although morphologically, it's normally clear that it isn't those, rather it is hairy cell. Also notably, hairy cell variant, whilst it doesn't have classically the BRAF V600E mutation, it does have mutations in MAP2K1, which encodes for MEK1, which is also part of this same MAP-K-ERK pathway and again drives cell proliferation. Waldenstrom's and lymphocytic lymphoma. So MYD88 mutations are really incredibly common in this population. 95 to 97% of these patients that are diagnosed have the MYD88 mutation. And although it's not exclusive, it really is a key driver, and it's nearly always the missense mutation L265P. It's a leucine to proline change. It is worth noting, though, that when I refer to L265P, really, when you're talking about NGS and genetics lectures, you should be talking about a transcript-specific amino acid change or a coding nomenclature change, always in the context of a transcript. So that is also important when you're looking up variants in the literature. So L265P is one of the older transcripts. It's in some of the assays now. It might be L250P or L252P or L260P. CXCR4 mutations are nearly always going to occur with the MYD88 mutation. They very rarely occur in other lymphomas, so again, are quite supportive of a Waldenstrom's diagnosis. And mutated patients do tend to have a higher disease burden at their diagnosis. Not surprisingly, TP53 is again associated with overall worse progression-free survival and overall survival, and patients with the MYD88 mutations who are also CXCR4 mutated do tend to have worse outcomes. Once again, how NGS could help is it will point out acquired resistance mutations to BTK inhibitors, in this case back to being through the BTK gene mutations themselves. Follicular lymphoma, so classically characterized by the 14/18 translocation. It's really the hallmark. It occurs in at least 85% of cases, and it places the BCL2 gene under the control of the IGH enhancer. So one very common mutated pathway seen in follicular is through epigenetic regulation, and that really is via histone modifications or chromatin remodeling, which you can see are the genes listed there. There is a prognostic score that incorporates this called the M7-FLIPI. So it has the 7 genes listed there, and it is predictive of event-free and overall survival in patients treated with R-CHOP. It's worth touching as well about scenarios when the diagnosis isn't clear. So I've talked about when you already really suspected one diagnosis, how NGS then can provide diagnostic, prognostic, or therapeutic relevance. This slide, which is from an article from Delaval et al. And colleagues, which I would recommend reading if you're interested in this area, talks about different mutational profiles and how that might help you better narrow down what you think could be the diagnosis in this patient. So if you see highlighted in yellow there, ATM BERK3 MEF2B would favor, say, a mantle cell, SF3B1, Notch1, XPO1 or exportin1, that can favor a CLL, which is what we sort of touched on earlier. And the same you can see there with some other lymphomas and how, again, gene results might help you in narrowing down your morphological provisional diagnosis. From a T-cell lymphoproliferative disorder, NGS can help demonstrate clonality. It would really, again, support a suspected diagnosis you already had on morphology by supporting it with a clonality finding. Follicular helper T-cell lymphomas, particularly angioimmunoblastic T-cell lymphomas, are characterized by DNMT3A, TET2, IDH2, arginine 172, and Rho-Gly17 valve mutations. So really what I'm saying there is a pattern that is very characteristic of follicular helper T-cell lymphomas, and that would be really supportive of that diagnosis if you were to find that genetic profile. One kind of point of caution, particularly with TET2 and DNMT3A, this audience is probably very aware that those are very common gene mutations found in myeloid clonal hematopoiesis. So just finding those amongst a possible lymphoma, I just recommend caution before using that to define a clonality and lymphoma support, because it could be just background clonal hematopoiesis. And just finally, in T, LGLs mutations in STAT3 and STAT5B, again, are very common and really, again, are supportive of a diagnosis that you thought the patient had on morphology. So just to bring part 1 together, NGS is a cost-effective and efficient way to obtain a really large amount of important molecular information, but it's not the only important information. It really needs to be combined with morphology, karyotype, and FISH testing. And really, it's the ability to combine all of those tests that will provide an accurate diagnosis for the patient. Patterns of NGS, in my opinion, are really there to support what you already suspect or really add some guidance in difficult cases. But I would think it would be a rare situation when an NGS result on its own is able to diagnose a patient. And molecular results, again, and this is my own opinion, are really likely to be increasingly used in prognostic classifications. And I think more and more trials are going to be sort of subdivided on molecular results in patients to try and work out the optimal therapy for patients with different molecular profiles and different lymphomas. So just moving on to, I guess, my lab in Sydney and our experience with the Liverpool Lymphoid Network panel. So I guess just touching on the workflow. So we extract DNA. We have different DNA extraction instruments, one that we particularly use for peripheral blood and bone marrow, and a different strategy that we use for FFPE samples. So that's always worth considering in your own lab when you might be pursuing lymphoid NGS, because you potentially will get all three, possibly even trifines. We quantify the DNA. We use that through a qubit 4 fluorometer. We don't use it in our lab, but there is a Genexus purification instrument that can be, I guess, synced with the Genexus sequencing instrument and do the extraction and qubitting for you. For the assay itself, we load at least 27.75 nanograms of DNA. I guess that's worth pointing out. It's a DNA-based assay. There's no RNA component at the moment into the appropriate well, and we prepare the run on the Genexus software. And that's really quite straightforward using the interface that the user sees on the software. And you can bulk upload a large number of samples at the same time. And then while you're sort of prepping the run, you can thaw and load all your reagents, particularly things like your barcodes, your primer pools, and your strips. So this, I guess, is a summary on the panel itself. So there's 60 genes. In most instances, it's the hotspots in the genes, not the whole of the genes. It comprises over 1,300 amplicons. And really, just because of that size, it's 4 samples per lane. And you can do a maximum of 8 samples across 2 lanes. For those that might be familiar with the myeloid panel, that can obviously do 16 because it's a lot less amplicons. So this is a maximum of 8 samples across 2 lanes. So actually, we've done 9 sequencing runs, but at the time I was producing this data, we'd done 8 sequencing runs. And it really, I guess, firstly, has got good quality metrics, it's good sample and good coverage metrics. So we haven't really had any concerns from it covering what it has intended to cover, except for a few caveats I'll touch on in an upcoming slide. So we've run 40 samples. We've sort of realized the limit of detection for our lab is 5%. And at that sort of threshold and above, there were 84 variants that we could compare with an accredited comparator lab. There were also 31 variants that we had in our assay that they don't cover, and vice versa. There was 11 that they only covered. So really, there was just 84 we could be confident that were fair to be assessed. So that incorporated 65 missense, 16 insertion deletions, and 3 splice sites. And I guess cutting to the chase, we were able to call all of them. And we were able to get 20 out of 20 variants that were accessible when we used the FRACP Lymphoid reference standard. So I guess at a 5% or higher VAF, we're currently able to call the 104 out of 104 variants. So just showing, I guess, the VAF results. So in the most instances, we're getting very, very similar VAFs. I haven't had any concerns as we've been running these samples for already really quite discordant results. So I guess being completely transparent, this has taken some effort from our lab to sort of optimize it. Some of the, I guess, key things, and I should say that the Thermo Fisher local bioinformatics support has been incredibly helpful. I should thank particularly Lauren. Don't know if she's listening, but she was hugely helpful with our endeavors here. And so some of the steps we had to do were, there were some amplicons that weren't well covered, particularly in GC-rich areas, and we were a bit, we lacked confidence that we would be able to call variants. So we thought the safest thing was to remove them from the bed file and adjust what we would state the assay was covering. That was one of the things we had to do. There are some false positive artifacts that were coming through, and so again, we worked with our local bioinformatics support to edit the variant baseline file to really prevent those from coming through and potentially impacting our accuracy by reporting false variants. And we did find that fairly obvious quite quickly that these same false calls were coming through regularly. I personally edited the filter chain, which is a functionality with the latest Genexus software. So we set ours at 10 to the minus 4 for the population databases. I guess the default is 10 to the minus 6. We found that a bit strict. And we sort of have tinkered with the parameters mainly to say that we're only really confident at 5% or higher. I should say, if anyone at any who's listening wants to email me or contact me regarding any further details about that, I'm very happy to be contacted. Regarding reproducibility, so we're still in the process of doing this, but we've run the commercial standard a couple of times and 4 samples have been evaluated twice. So far, the SeraSeq 20 out of 20 variants we've called on both times that we've run it. And the samples that we've repeated, we've found, again, at the VAF 5% or higher cutoff, we've called everything without any concern on repeated running of those samples. So limit of detection, just to touch on. So at the 5%, with the editing of the bed file, which is what I was trying to touch on earlier. So there are variants that we wouldn't get when we realized we weren't covering those amplicons very well. But with the optimized target bed file, we have no concerns at a 5% VAF. For completeness, those are the variants there that we've missed on the 3 to 5% VAF. We got 12 out of 17. I guess when they are called between 3 and 5%, I've been confident that they're real, obviously excluding the false positives that we quickly identified. But I'm not sure we could very confidently say that the limit of detection is 3% because of the sort of variants that are listed there. And some are missense, and some are dupes, so it wasn't clear just one particular type. And below 3%, we haven't called anything that the comparator lab has called, but to be fair, they have unique molecular indexes and they are not part of our assay, so I'm not sure that's a fair comparison. And at this point, it says that we will perform dilutions. We have performed dilutions now, and again, that confirmed our 5% threshold as suspected. So I guess bringing this all together, we generally, as from the Genexus broadly, just really like it. We use it for our oncomine myeloid assay. We have a lot of solid tumor assays, and we will be looking to set this up formally with the lymphoid assay. And it, as some people would already be aware, uses minimal hands-on time and really allows us significant time saving in our lab. The Liverpool Lymphoid Network panel, having had to work with our local support, which was really, really supportive, I have to say, to tinker with the bed file and some of the filtering and really kind of block out these false positives. I'm now confident in our panel, and it really, I feel, has shown excellent accuracy, reproducibility, and an established 5% level of detection. So thank you very much for listening. I hope it's been helpful and insightful for those interested. And these are my references. And as I said, very happy to be contacted by anyone that would like further details on our experience. Thank you very much.